Double crush syndrome is a fascinating and complex condition first described in 1973. It occurs when a nerve is compressed at two separate points along its path, making it more vulnerable to damage. In clinical practice, this often involves the ulnar nerve, which runs from the neck down to the hand. While double crush syndrome is better known in cases like cervical radiculopathy combined with carpal tunnel syndrome, its occurrence in the ulnar nerve, especially at both the elbow and wrist, is quite rare. Understanding this syndrome is crucial as it can complicate diagnosis and treatment, often requiring a high degree of clinical suspicion and specialized testing. Ulnar nerve is a major nerve of the arm responsible for sensation and movement in the hand, especially the fourth and fifth fingers. It passes through two key anatomical tunnels, the cubital tunnel at the elbow and Guyon's canal at the wrist. Compression at either site can cause numbness, tingling, and muscle weakness. When both sites are affected, as in double crush syndrome, symptoms can be more severe and harder to pinpoint. This makes the ulnar nerve's journey particularly important in understanding how double crush syndrome develops and why it can be so challenging to diagnose. Patients with double crush syndrome of the ulnar nerve, often present with numbness and reduced sensation in the fourth and fifth fingers. Muscle weakness, especially in tasks like tying shoelaces or using chopsticks, is common. Physical exams may reveal signs such as Weitenberg's and Egawa's signs or atrophy in the first web space of the hand. However, these symptoms can overlap with other conditions, making it difficult to distinguish between single and double site compression. Careful assessment of hand function and muscle strength is essential for clinicians to suspect and investigate double crush syndrome. Diagnosing double crush syndrome is tricky. Standard clinical exams may not clearly differentiate between compression at the elbow and wrist. Electromyography, EMG, and nerve conduction studies (NCS) are helpful but often miss subtle compressions, especially if inching tests at the wrist aren't performed. Imaging such as ultrasound or MRI can reveal nerve swelling or cystic lesions, but these findings must be interpreted alongside clinical symptoms. Without a high index of suspicion, double crush syndrome can easily be overlooked, leading to incomplete treatment and persistent symptoms. Let's look at a real case. A 47-year-old male golfer developed weakness in his left second finger. EMG and NCS confirmed double crush syndrome, with compression at both the cubital tunnel and Guyon's canal. Imaging revealed a ganglion mass compressing the nerve at the wrist and swelling at the elbow. Surgery addressed both sites, removing the ganglion and relieving the nerve. At follow-up, the patient's muscle atrophy improved, and his hand function returned to normal. This case highlights the importance of thorough evaluation and the potential for full recovery when both compression sites are treated. Treatment for double crush syndrome depends on symptom severity and patient preference. In the study, 4 patients underwent surgery at both the elbow and wrist, while 3 received conservative management. Surgical options included nerve transposition or decompression, often with excellent results. 2 patients achieved complete symptom relief. Conservative treatment involved lifestyle modifications, splinting, and nerve gliding exercises. Most patients improved, though some had lingering mild symptoms. The choice between surgery and conservative care is guided by clinical findings, patient goals, and the presence of space-occupying lesions. Outcomes for patients with double crush syndrome were generally positive. Among those who had surgery, most experienced significant or moderate improvement in hand function and satisfaction. Conservative treatment also led to good results in milder cases. Importantly, no major complications or recurrences were reported during follow-up. However, patients with longer symptom duration or multiple neuropathies tended to have slower or less complete recovery. These findings underscore the importance of early diagnosis and tailored treatment strategies for optimal results. Double crush syndrome remains a controversial diagnosis, especially regarding its true prevalence and the best approach to treatment. Some experts question whether abnormal findings at 2 sites always mean both are clinically significant. Ethical concerns arise when deciding whether to operate on both sites or just one, especially if symptoms are mild. The study suggests that a thorough explanation to patients and shared decision-making are essential. Ultimately, the presence of double crush syndrome should prompt clinicians to consider more comprehensive diagnostic and treatment strategies, especially in cases of persistent or unexplained symptoms. Summary: double crush syndrome of the ulnar nerve is rare but clinically significant. Diagnosis requires a combination of clinical suspicion, specialized testing, and imaging. Both surgical and conservative treatments can be effective, but early intervention leads to better outcomes. The study highlights the need for more research and clearer guidelines, as well as the importance of patient-centered care. As awareness grows, clinicians will be better equipped to recognize and manage this challenging condition, improving quality of life for those affected.